Welcome. So, if you're a medical trainee, you know how overwhelming cardiac diagnostics can feel. Today, we're going to cut through all that noise. We're going to break down the most important tests and decisions into a clear, practical framework that you can actually use, right at the bedside.
Okay, so here's our game plan. We'll start with the absolute fundamentals, the cornerstone of everything. Then we'll dive deep into coronary artery disease and how to pick the right tests. After that, we'll tackle structural problems, figure out arrhythmias, and wrap it all up with the critical risks and the big takeaways.
All right, first things first. Before we even dream of ordering a fancy scan or an expensive stress test, we have to ground ourselves in what really matters. We have to start with the basics.
This is the classic scenario, isn't it? A patient comes in with chest pain, and your mind just floods with all the possible tests you could order. But here's the thing. Your most powerful tool isn't the most advanced one. It's actually something you have with you every single day.
And this right here, this might be the single most important point of our entire conversation today. Technology is amazing, for sure. It helps us confirm what we suspect. But it should never replace taking a meticulous history and doing a really thorough physical exam. Just think about it for a second. Hearing that faint, early diastolic murmur of aortic regurgitation with your stethoscope, that one finding could be the only clue that steers you away from CAD and towards a valve problem. Your skills in cardiac physical diagnosis, what you can hear and feel, are absolutely paramount. So, with that foundation firmly in place, let's tackle the most common challenge you're going to face: how to investigate potential coronary artery disease, or CAD.
Before you even think about ordering a test, you have to stop and ask yourself, how likely is it that my patient actually has this disease? This whole concept, pre-test probability, is what separates smart, targeted testing from just a random scattergun approach. It really is the key that guides every single decision that comes next. So here's the deal. We don't stress test everybody. If someone's pretest probability is super low, a positive result is probably just a false positive, right? And if it's super high, well, you should probably just move on to a more definitive test. Stress testing really shines in this middle ground, this sweet spot, where the result is actually going to change what you do.
Okay, so you've decided a test is needed. Now you're at a fork in the road, and you have to make a big decision. Are you looking for the effects of a blockage on the heart, or are you trying to find the physical blockage itself? This is that fundamental choice between functional and anatomic testing.
What's so great about this slide is how it just simplifies everything. Think about it like this. Functional tests are all about the physiology. Is the heart muscle getting starved for oxygen when it's working hard? Anatomic tests, on the other hand, they're about the plumbing. Are the pipes, the coronary arteries, actually clogged up? So why are these functional tests so sensitive? It's all because of something called the ischemic cascade. See, by the time a patient actually feels chest pain, a whole series of events has already happened inside the heart. Our imaging tests can pick up on those really early changes, like problems with blood flow or how the heart wall is moving. That's what makes them so powerful. So, which test do you pick? This table lays it out pretty clearly. Look, if your patient can get on a treadmill and their baseline ECG is normal, a simple exercise ECG is a fantastic place to start. Plus, you get all this great prognostic info just from how well they can exercise. But if their baseline ECG is already abnormal, you're going to need pictures, either an echo or a nuclear study, to really know what's going on.
And what about on the anatomy side? Well, a coronary CT angiography, or CTA, is a fantastic, non-invasive way to see the arteries, especially in younger folks. But, and this is a big but, for patients who have a really high probability of disease or are coming in with an acute coronary syndrome, the gold standard is still invasive angiography. Why? Because you can diagnose and fix the problem with a stent, all in one go. Okay, let's shift gears. We've talked a lot about the pipes, the coronary arteries. But what about the engine itself? The heart muscle, the chambers, the valves? That brings us into the world of structural heart disease. When you're thinking about structural disease, your number one tool is the transthoracic echocardiogram, the TTE. This thing is the absolute workhorse of cardiac imaging. You hear a big murmur with your stethoscope or you're worried about the heart's pump function, a TTE is almost always the first test you should reach for. Now, sometimes the standard TTE just can't give you a clear enough picture. In those cases, we bring in the TEE, or transesophageal echo. By putting the probe down the esophagus, you get these incredible high-definition views of the back of the heart. The trade-off, of course, is that it's more invasive.
but the image quality, it can be absolutely game-changing.
And then sometimes you need a very specific key for a very specific lock. This is a perfect example. Cardiac amyloidosis can be really tough to diagnose, and telling the subtypes apart is critical for treatment. A PYP scan is a specialized test designed to do just that. It lights up the ATTR subtype with incredible accuracy.
All right, let's move on to what can be a really tricky diagnostic puzzle: arrhythmias. The patient tells you they have palpitations or feel dizzy, but by the time you see them, their symptoms are totally gone. So how do you catch a problem that's always playing hide and seek? Here's the crucial point. No matter how intermittent the symptoms are, you always start with a simple 12-lead resting ECG. Always. It gives you that baseline electrical snapshot of the heart. And who knows, you might just catch an underlying clue, like pre-excitation, that points you in the right direction.
Now, what I love about this slide is how it just makes so much sense. It really simplifies the challenge. The logic is so straightforward. The less often the symptoms happen, the longer you need to monitor the patient. If they're having palpitations every day, a 24-hour Holter might do the trick. But for fainting spells that only happen once every few months, you might need an implantable loop recorder that can watch the heart for years.
Whew, we've covered a ton of ground. So now, let's bring it all home. We're going to review the most important safety checks and the high-yield takeaways that you absolutely need to remember from all this. This right here is non-negotiable. Before you send any patient for an exercise stress test, you have to run through this mental checklist. These are the absolute do not pass go contraindications. Putting someone with one of these conditions on a treadmill can be incredibly dangerous, so please know this list inside and out.
Let's lock in our first key point. Never ever underestimate the power of a simple exercise ECG. It works, it's everywhere, and the information you get about how much your patient can do, their functional capacity, is a seriously powerful predictor of their long-term health. And here's our second big takeaway. If that baseline ECG has some abnormalities on it, like a bundle branch block, or if your patient simply can't exercise, that's your cue. It's time to move on and add imaging, either an echo or a nuclear study, to get a clear answer. And this really brings us to a huge question for the future of medicine. Our technology is just unbelievable. It gives us these crystal clear pictures inside the human body, but does it replace the timeless skill of actually listening to and examining our patients? Will the stethoscope just become a relic in a museum? That's the critical challenge, the balance that your generation of clinicians is going to have to navigate. Thanks so much for joining us.